early identification of patients at inherited risk for cancer really makes a difference because it can prompt enhanced cancer surveillance. And in prevention and early detection really saves lives, and so this justifies genetic testing. But the field of cancer genetics has been changing. We moved from a gene-by-gene approach to a multiplex gene approach, and that allows for the simultaneous analysis of multiple high and moderate penetrance genes. But as we've seen from recent data, the more genes you check, the more pathogenic variants and also variants of uncertain significance are found. So this adds to the overall level of complexity and interpretation of these tests. So a number of questions still remain as to what's the overall clinical utility of these tests, as well as what's the added value and added diagnostic yield of using multiplex testing. And so we really tried to answer that question with this study that we're doing, which is a multi-center prospective cohort study. It has 3 centers, which include LA County, USC Norris, as well as Stanford Cancer Institute. We've recruited 1,000 patients using a 25 gene panel from Myriad Genetics. This panel includes BRCA1, BRCA2, as well as a number of the Lynch genes. And what we found is that for each patient that was enrolled, we created a differential diagnosis where you could formulate up to 8 inherited cancer syndromes. And we checked that differential diagnosis to the overall genetic test results. And what we found is that 70% of the time, we got it right. So we're good at predicting as to what genetic test result was going to come out. But 26% of the time, we didn't. And some of the genes that we missed were really important genes like BRCA1, BRCA2, as well as some of the newer undefined genes like CHEK2 and ATM. So based on that, we found that we feel that there's added significant contribution from using multiplex panel approach, and that there could be clinically significant implications to this.